So the first oncologic emergency that we can possibly deal with is superior vena cava syndrome. What is the function of the superior vena cava? What does it do? It brings blood and fluid from the upper part of your body down to the heart, right? So what will happen is, and usually in late stage lung cancers, lymphomas, sometimes breast and esophageal cancers, the superior vena cava will be compressed or occluded by tumor or other issues in that patient. And so you'll have a blockage of the venous return from the upper body. And it starts backing up into the head and the neck and the upper torso area. So the early sign of superior vena cava syndrome is going to be what is called Stokes sign. And that is a tightening of the collar of the shirt or the blouse because of engorgement of the veins of the venous circulation in the neck area. Periorbital edema is another early sign of that patient developing superior vena cava syndrome. If we don't treat it, if we don't correct it, then patients will start getting arm and hand edema. They'll get shortness of breath. Will they get crackles in the lungs? Why not? Right, it's a right-sided issue. So you're getting superior vena cava, you're getting peripheral edema, but just in the upper torso. So you're not having a backflow of fluid into the lungs. So you're not having crackles in the lungs, but you are going to have upper body edema and arm and hand edema. And then late stages, patients will begin to have mental status changes. They can become comatose, become very hypotensive because the cardiac output is diminished. If you don't have good venous return, you don't have good cardiac output. So the treatment is going to be high-dose radiation to shrink the tumor that is compressing the superior vena cava, chemo to shrink the tumor, or insertion of a stent to open up the SVC so that it will drain appropriately. We can have spinal cord compression, where either the primary tumor is in the spinal cord or in the vertebrae, or metastatic tumors will grow and compress the spinal cord. This is where patients will have sensory and motor deficits because of the compression of the spinal cord. So they will have pain, numbness and tingling, bladder and bowel control issues. And our treatment is going to be steroids to shrink the tumor, radiation to shrink the tumor, or surgery to either remove it completely or to debulk it so that the symptoms are for palliation purposes. What is hypercalcemia? Too much calcium in the bloodstream. And the reason that patients with cancer get hypercalcemia is for a couple of underlying problems. If they have bone cancer, the cancer that's in the bone causes bone deterioration and release of calcium into the bloodstream. Hypercalcemia can also occur as one of those paraneoplastic syndromes that we talked about when it came to lung cancer. Some tumors will excrete parathyroid hormone, and parathyroid hormone causes the bones to release calcium. And then you have the patient who has cancer, who's debilitated, who's weak, laying around, so you've got mobility, immobility issues, and you lose bone mass, bone density because of that immobility as well. So what are the signs and symptoms of hypercalcemia? What's that? No, not the muscle twitching. Muscle twitching is from hypocalcemia. So the Trousseau's, the Chavostics, or all those other things that you learned about in, what was it, in 110 or 200. Those are hypocalcemia. Hypercalcemia, you have decreased reflexes, loss of muscle tone, muscle weakness, nausea, vomiting, constipation. So the opposite of kind of those classic signs of hypocalcemia that you drilled into your head with all those different signs that you learned in other semesters. The treatment for hypercalcemia is to orally hydrate that patient, to dilute, IV hydration to dilute. Calcitonin, which is a medication that helps the bones to reabsorb the calcium. You may also see calcitonin given to the little old lady with osteoporosis. There's a nasal spray, Myocalcin nasal spray, that people with osteoporosis can take and helps their bones to reabsorb calcium and strengthen the bones. If we cannot lower the calcium levels by all those other means, the patient may have to undergo dialysis. No, because it's not the parathyroid that's malfunctioning. The tumor is releasing too much releasing parathyroid hormone. So you don't want to, put them into a hypocalcemic situation by removing that. Pericardial effusion, cardiac tamponade. What is that? Pressure building up in the pericardial sac around the heart. So it's compressing the heart, making it hard for the heart to pump, reducing your cardiac output. So the signs and symptoms we're going to have are muffled heart sounds, fatigue, shortness of breath, and our treatment is going to be a pericardiocentesis, a needle aspiration of the fluid that's surrounding in the pericardial sac so that the heart can now contract and relax appropriately. Pericardiocentesis. Another potential complication, oncologic emergency, is DIC, and you all know all about that because that was just on the last exam, so we don't need to cover that. SIADH, what is that? So it's too much antidiuretic hormone. So cancers can affect pituitary function, causing too much antidiuretic hormone to be secreted. Or it can occur as a result of one of those paraneoplastic syndromes where the tumor itself secretes ADH. And when you have too much ADH, you have a massive fluid retention. Patient cannot diurese. Patient becomes hyponatremic because of hemodilution. And patients will go through stages of SIADH until the symptoms become so severe they go into coma and they die. So you need to correct that underlying cause. If possible, remove the tumor that is secreting the ADH. Severe strict fluid restrictions, 500 to 1,000 milliliters a day. And then slowly increase sodium levels to try to raise your sodium. 500 to 1,000 per day is the fluid restriction for this patient. I know. I mean, you could do 500 with, one morning, one morning group of pills. And the last complication is Tumorlysis Syndrome. What does lysis mean? Destroying or breaking down. So Tumorlysis Syndrome is really a positive sign that whatever the treatment you're doing for that patient is working, because large amounts of the tumor are being destroyed. And certain types of tumors, the doctors know when they do chemotherapy on a particular type of tumor, large amounts of that tumor are going to be destroyed with that chemo. So this is something that can be anticipated in many patients, depending on the type of chemo they're getting and the type of tumor that they have and the way it reacts to chemo. Because while it's a positive sign that the treatment is working because tumor is being destroyed, it's being destroyed at a rate too quickly for that patient's body to filter all of the debris and the toxins that are the result of all that destruction of tumor. Because when you have cell destruction, you have higher levels of potassium and myoglobin and all kinds of other toxins, purines, uric acid. All of those build up in the patient's bloodstream because their body just can't excrete them efficiently. It's happening too quickly. So when we anticipate that patient would be at risk for tumor-lysis syndrome, we overload them with fluids prior to their chemo. And we're talking 3,000 to 5,000 milliliters a day for the 2 days prior to chemo. So we overhydrate them. And then during the chemo, we're going to give them a lot of fluids. And then after the chemo, we're going to give them a lot of fluids and diuretics so that we can flush all those toxins out. We also have to give them medications that are going to reduce the purine levels. So allopurinol, which we give for what condition? Gout. Reduces the purines, because what will happen is if the purine levels elevate in your bloodstream, they precipitate in your kidneys and form crystals and put you into renal failure. So you need to prevent that. So you need to give allopurinol to reduce the purines so they don't crystallize and cause renal failure. You need to give them Kayexalate. What does Kayexalate do? It takes the potassium out of the bloodstream. Glucose and insulin will also remove the potassium. And again, dialysis if all of these other methods do not work. So our legal case study as it relates to cancer, our plaintiffs are the surviving son and daughter of a terminal lung cancer patient whose arm was broken by a student nurse, not a Goodwin student. The patient was diagnosed with metastatic bone disease, and they claimed the student was negligent to move the patient without using a draw sheet. And they said, but for the fractured arm, she could have been cared for at home versus having to go to a skilled nursing facility in her final days. And that the family had to spend over $26,000 for nursing home care because they couldn't care for her at home. The defendants claimed that there was no evidence that the cancer had spread to the humerus and that lifting by the arms was appropriate, and also claimed that the disease progression would have left the patient in the same state of disability. So who do you think won this case? Plaintiff or the defendant student nurse? I hear some people the plaintiff, some the defendant. You're with the student nurse, huh? Bad move. No, the student nurse should have known, or her instructor should have known, that the patient was at risk for pathologic fracture because of her bone metastases, and they should not have grabbed her arm to move her up in the bed. They should have used a lift sheet. You shouldn't. $92,000 for the plaintiff in this one. Okay, we are going to end here because I can tell you're fried.